afternoon, everyone, and welcome to today's edition of Black Health Trust. We hope that you are having a wonderful day, and we're so happy that you chose to spend some time with us. We're looking forward to having a very vigorous conversation today. And without further ado, I'm going to turn it over to Dr. Randall Maxey.
Good afternoon, everyone. Thank you for joining us for a period of this Sunday afternoon, the day that God hath made. And thank you for joining us, Dr. Barbara Neighbor Stevens, Dr. Ivan Walks, and Dr. Jocelyn Hines. I celebrate your new sign, Dr. Hines. Very good. So for the past 2+ years, we have gone from starting every session with COVID vaccines, immunotherapy for COVID, social distancing, and all of those things remain very high on our minds and are very important. But there's more to life than just the pandemic. You have to live through the pandemic, you have to live after the pandemic, and you have to live through the next pandemic. So in talking with Dr. Neighbor Stevens over the past several days, she again suggested, well, what can we really do for ourselves? What are the things we can do beside masking, beside vaccines? What do we do? There's a higher maternal rate of death among Black women in childbirth. There's a higher rate of stage 4 cervical cancer. We lead in every category of death and disease that there is, I believe, except Tay-Sachs disease. I think that's true, Barbara.
I think that might be true.
Huh?
I said, I think that might be true. We might check with Dr. Walks.
Okay. Is that true, Dr. Walks or Dr. Hines? We lead in all those categories?
I was just going to say, luckily, I'm on mute. I wouldn't say in every category, Dr. Maxey. There are probably some, in addition to Tay-Sachs, there are some other ethno or cultural specific illnesses that we probably don't need, in which we probably don't lead.
Well, let's say we lead in too many of them.
There we go. The point is well taken, right? Like there's two. It's a prize we don't want to win, right? Can we give it away?
Right. So we want to talk about what we have to do and what we can do. Now we started a week or so ago with Dr. Cutter talking about how to cut death risks from cancer. And this is important enough that we need to review it again. Mm-hmm. And coming up in the next 4 to 6 weeks, we're going to present in more detail some of these things that are with us no matter what. So let's get started. And I appreciate my co-hosts and moderators and our advisory board chiming in at the appropriate time to discuss. I put together a few slides for discussion. Let's go with the first slide and then immediately to the second slide, Simon.
While he's pulling that up, Dr. Maxey, can we just say again how wonderful it is to have Simon and to have him available to help us? It's really, really amazing.
Oh, yes, it is. He is truly amazing. And I don't know if we've ever said very much about Simon other than that he's an avid football fan. But Simon happens to be not only an IT genius, he's a musician. He writes, he composes. I won't say he does symphony music, but he does rap music and other things. So we're just so glad to have a talented person like that. So I'm very proud of Simon. And
Yes,
I've
sir.
known him an extra long time, since he also happened to be the son of my sister, my favorite sister. So Simon, no, you want me to share my slides?
We're watching the slides. You can really just start talking.
Okay, but I need to put my slides up. This is not the one that I want. I had shared a slide and you took it down, Simon. Can you reshare my screen?
On the bottom row of your screen, you should see a green button that says share screen, and then it'll give you an option for the windows, and then click your PowerPoint screen. There you go.
Okay, there you go. All right.
And now you see why we need Simon.
Okay.
So we will add to Simon's kudos on the spot instructor.
Okay. Okay. So now, the first thing, and I'm going to pitch this one to Barbara, neighbor Stevens, MD, MPH. Why do we need to get screened in the first place?
Well, let's think about it. It is true. The human body is a wondrous work, but we are expected to take care of it. And one of the most important ways to take care of any machine is to have regular checkups, because there are things in a machine that's being used all the time that at some point or another is going to need some attention, whether it be replacement, tuning up, or just plain oiling. So like any other machine, the human body needs to get a checkup from time to time. And we call these checkups preventive screenings, but it is not an optional thing. Sometimes I think people think preventive means optional. It is not optional, because I promise you, if you don't get that oil checked in that car and it's leaking out, at some point, that car is going to stop on you. So likewise, if we don't check up this body from time to time, it is going to let you know it doesn't appreciate the care you're giving it.
One of the things that I do in a playful but serious way when I see a patient, I say, what's the medicine you're taking for your high blood pressure? They'll say, Doc, I don't know what all that stuff is. I just take it. It's a pink pill or it's a red pill. I said, wait a minute, what kind of car you drive? I drive a Buick 225. What kind of oil you put in it? 10W30. And they can tell me every detail of what they do for that car. But the most important thing they drive, they don't know what they're putting in. So this is very important that we look at some of these details.
First of all, Dr. Maxey, if they're still driving a Buick Electra 225, they need to buy a new car, because it's using leaded gas and it's polluting everything. So let's start right there.
Well, I'm from California, and pretty soon they're not going to be able to do anything in California that's not electric.
So let me say one more thing about screening, Dr. Maxey.
Okay.
You know, when we think about changing oil in our car, most people will tell you, if they've ever done this, that if you don't change the oil in your car or check the oil, at some point you're going to get a message that you have to do something. Screenings are almost invisible, because it's something that you have to believe you need to go do, or the results are going to be catastrophic, but not for everybody, right? I might be able to go my whole life without getting screened for prostate cancer and not have it. And I think that's the challenge, is that there are people who are going to say, well, I don't have to be screened because my uncle never got screened and he never got sick, or my auntie never got screened and she never got sick. And so this whole thing about convincing folks really does come down to what you were just doing, Dr. Maxey, which is a relationship with your patient that really allows them to connect with you and trust you and believe you. So if you want to talk to them about, about the Buick 225, they know that, as you said, you're kidding, but you're serious. That's how you build relationships, and you convince people to do things so they don't listen to the one guy in the barbershop that drinks and smokes every day and is 95 and never spent a day in the hospital. We don't want to listen to him. We want to listen to Dr. Maxey.
Yeah. And plus, he might have lived to be 120 if he hadn't been drinking.
The other thing too that I oftentimes will talk to my patients about when it comes to screening, especially when they say they're too busy or they feel fine, why should I be bothered? What are the things that you're too busy doing, right? And the reality is, if you wait until you start having symptoms of something or until there's something wrong to go get something checked out, you're going to still miss out on those things, but it won't be on your terms, right? At the current time, we get the option to make a schedule. But if you wait until there's a funky mass growing out of something, the time that you miss may not be on your terms. So let's do it while it's on your terms.
Nobody wants a funky mass out there.
Yeah, no. I've seen some.
Yeah.
So why don't you react to this slide, Dr. Hines?
Sure.
Can you read it?
Huh?
Can you read it?
Yep, got it. Yep. So mammograms. So the age for mammograms is essentially to start at 40. And if you're higher risk, you can start earlier with breast cancer screenings. It may not be in the form of mammograms. There are other ways to do breast cancer screenings, but certainly there used to be a lot of talk about, how painful mammograms are. And that was oftentimes a reason why people wouldn't want to go. If you happen to be someone who's eligible for a mammogram and haven't gone for that reason, I will also just let you know that, like many things, the tools for breast cancer screening have been updated, right? So it is not necessarily the same process that it used to be. And I'm not saying it's terribly that it's comfortable, but it's not as uncomfortable as it used to be in the past. The other thing I'll also say is this, waiting until you find a lump, right, to decide to check on something is often, so here's the deal. The worse the problem is when you try to fix it, the harder it is to fix. So, and it's the same with, like we were talking about, with any other thing in your life. If you wait till the computer has already shut down, right, and you've lost all your data and all your photos and this, that, and the other to say, hey, I wonder if I have a virus, right? If you get it checked out, right, when things start seeming a little weird, then you're better off. It's the same with screenings and breast cancer screenings. Again, Black women, it's a prize we don't necessarily want to be winning as far as, mortality rates and things like that from breast cancer in particular. But the sooner you get screened, the better. That way, if there's something there, it can be dealt with. And again, lots of times people don't want to go get screenings because they're scared to get results. But ignoring a problem or not knowing about something doesn't mean that it doesn't exist. Just because you've decided to not know doesn't mean it's not there.
I want to make a comment on something that Dr. Hines said. Now, let me preface this by saying every day I pray for patience and tolerance. But on this point, I think I may be right. I have a great deal of difficulty accepting as an excuse that something is going to be uncomfortable or painful. Pain is certainly a relative term, and people have varying degrees of tolerance of pain and discomfort. But if you're sitting across from me and you've got body art on, and you're telling me you don't want to get a mammogram because it's too painful, or you're sitting across from me and you've had a baby vaginally, and you tell me that getting a mammogram is too painful, I have to put those statements in the category of excuses. And I like to call things what they are. So let's not fall into the trap of excuses as we go through this whole the rest of this program in our own mind, saying, well, I'm not going to do this because let's put the excuse trap up on the shelf for the rest of this program.
So Dr. Walks, you're a director of public health for DC. And early in my practice, I had a patient who I can't name, but he was a male. He was approximately 65 years old. And I diagnosed a lump in one of his breasts, and he had breast cancer. And 2 years later, she had surgery on that first one, and 2 years later, he developed the same cancer on the other breast. So I don't know if you might be familiar with the relative frequency, but men also get breast cancer, right?
Yes, they do. Yes.
Well,
they do.
let me say this about that. When I was the Director of Public Health, Commissioner of Health, whatever my title was back then for Washington, D.C., we had, and men are notorious for not checking everything. And so having a relationship with a woman that cares about you is very helpful, because oftentimes they will push you to get your screenings and they will push you to get your exams because they don't want to take care of your sick behind. When you've let everything go and it's been 3 years later and now they've got to take care of you, they don't want that. So they will push you out. The other folks who will push you out are your children. And so we set up something with the basketball team there to give tickets to kids who brought their dads to screenings. And we had Magic Johnson come out, and the man that we had that was a breast cancer survivor was Richard Roundtree. Now, Dr. Maxey, you're not old enough to remember this, but Richard Roundtree was the original Shaft from back in the 70s. And he was very clear about his breast cancer diagnosis, that he was a survivor, and he was that spokesman, letting brothers know it's okay to be Richard Roundtree and be a man and have breast cancer. So yes, it's important. We had a lot of people come out to that event. We gave away a lot of tickets to fathers and sons and fathers and daughters. And I think it's important for us to look to opportunities in our community to have people who are willing to come out and be examples of these things that are so important. It is awful to think about a man with lumps you can find who is not following up because he doesn't think it's manly to have breast cancer, or he doesn't think men get breast cancer. So that's my very long answer to your short question, Dr. Maxey. Yes, men have breast cancer. I have a question though, maybe Dr. Hines or Dr. Neighbor Stevens knows this. Sometimes we listen to half of the statistics, and I think I read that Black women do not get diagnosed with breast cancer most often, but the mortality rate, Black women die more from breast cancer. And I think it's because Black women are diagnosed later. Is that correct?
Yep, that's.
But when you get it at a younger age, and when I'm saying a younger age, I'm talking between 30 and 40,
yep.
Statistically, they have a more aggressive tumor.
The other thing I will also say to your point about male breast cancer, while it is rare, it's only about 1% of cancers. It's really important to know about because it is absolutely something that is considered a high risk. If you are a first degree relative, meaning mother, father, brother, sister, probably even aunt or uncle, right? Of someone who had a male that had breast cancer, it means that you're at increased risk. And the other thing that I would also say is, for men, knowing the family history in your medical history, for everybody, knowing your family's medical history is important, right? Because one of the risk factors for men to have breast cancer is having particular genes or higher frequency of breast cancer in the family, right? So one of the things that I also think that we have to do a better job of in general in our community is talking about the conditions, the diseases that we have, certainly amongst our family, because lots of times you don't even know that, sometimes your brother, your sister even has a certain, diagnosis or chronic condition, but it's important, right? Because sometimes the kids need to know, your nephews and nieces need to know, your grandkids need to know.
So Dr. Can I make one last point on this? And actually, it's not just breast cancer, it's on all the cancers in general. Just because you do not have a family history of any particular cancer there is, does not mean that you are not at risk for having it, because the longer you live, the greater your chances are for developing cancer for a lot of reasons. Mm-hmm. But one that we haven't talked about much, but and we're going to spend some time on this later in the year, is my hope, my plan, is that we don't know what all we've been exposed to. We don't know what we have been eating and drinking. We don't know the effects of things that are around us. Down here in the South, there are a lot of ads on right now about the situation at Camp Lejeune and all of the people that were exposed to toxic substances at Camp Lejeune. But you don't have to go to a military base. There are many communities that are built on dump sites, which are constantly leaking carcinogens into the soil and into the groundwater. Or you may be living near a plant that is putting out fumes that eventually that are toxic and that over a period of time can create cancer. So we are in a state of not knowing. So what do you do when you don't know? You go get checked.
Find out.
Yeah,
let me just add a final comment to that, Dr. Maxey. Dr. Hines talked about how important it was for us to know our family history. Trust and believe that a lot of people will not tell you when they have stuff that they think is embarrassing. Yes, I had breast cancer and I had a lump removed or what have you, but I'm not telling everybody about that. So when somebody asks, "Oh, Uncle Joe, I'm checking my whole family history. Have you ever had this or that?" Nope, and nope, because we're not talking about that. So it's important to talk about things and normalize that activity in our communities and in our families. And the last thing I'll say, and this goes back to what Dr. Hines said, it is really nice for me to know that breast cancer in men is only 1% of cancers. If you're that 1%, and somebody is that one. I hate statistics. I hate them because they have zero relevance to the individual. You may be that individual person that has something going on and makes you 1 in a million. It's not the right way to be special. It's really not. Mm. So go get screening, even if it's not that common for you. Peace of mind is great. And if you've been screened and you know, hey, we don't need to see you again for 2 years or 5 years, that's the position you want to be in. I've had my screening, I'm good.
So let's talk about this just a little bit more. Let's say there's a 55-year-old man and he came to see me, and I noticed that he has what we would call gynecomastia. And gynecomastia is large breast in a male. And my first question to him is, do you smoke? He said, "No, I don't smoke, but I do use pot. Oh. I smoke that. And I also eat tofu." Now, those are both two things that can be behind gynecomastia or enlarged breast in a male, not necessarily the diagnosis of cancer, but gynecomastia can be a mask for breast cancer. Now, would that person be sent for a mammogram, Dr. Hines?
No, and in the grand scheme of gynecomastia in the male, the first most common reason, obesity, right? That's the most, outside of any of the other substances or the diet, or it's obesity, is the most common reason. So let's talk when we're talking about go get your screenings. At the current time, there is no standard recommendation for a male to have breast cancer screening with a mammogram. Now, to your point, if you're talking about somebody who has significant gynecomastia, I would absolutely expect at least a manual breast exam, right? Because again, you would also be asking that individual about, any other symptoms, any discharge, any changes. I'd be looking for, are they the same? Is there symmetry? Do they look the same? Looking for any differences in the skin, those kinds of things, right? Discharge, like I said, pain, lumps, all those kinds of things. And assuming that so let's also be clear, a physical exam, a manual breast exam is a form of cancer screening. Now, to be clear, right, it is not the gold standard for women as far as what the recommendations for breast cancer screening are. It used to be part of the recommendations in the past. It is not anymore. And the reason I'm making this distinction is because some people think that you can go get tests for everything, right? Like you could go get, because I'm concerned about something, there should be a screening test for it. And the reality is there are not necessarily screening tests for everyone or for every disease. So there are guidelines, right? And what you have on the slide here is an example of the guidelines that are for mammogram, breast cancer screening in a normal risk individual. If you have higher risks, for example, in the scenario that Dr. Maxey is referring to, there may be things that you do differently because you're outside of that normal risk stratification.
One of the things that Dr. Walsh reminded me of, many of us are very much into family reunions, and my favorite sister is our family historian. So she has this whole website where she has traced us back to West Africa and everything. But this provides a good chance for people to put the real family history down of what did Aunt so-and-so have, what did so-and-so die from, so that those coming behind us can have an idea of what their risks are for. So this should be a good thing that we do.
Dr. Maxey, before you leave your 55, before you leave your patient with a gynecomastia, I think it's important, those of us who are physicians, when someone comes in, you want to take a good history. You want to have a standard set of questions that gives you a picture of what may be going on with that person. And though obesity is the most common cause of gynecomastia, gynecomastia can be caused by medications a person's taking. And so you really want to do that. I think most of us doctors do that. We get a complete list of what medicines people are on, so we don't prescribe something that will interact poorly with what they're taking. But again, some things can be clues, like abnormal movements that people will try to mask by kind of moving the way that their body may move, so you may not notice it. But gynecomastia is one of those things that's for me is a red flag, because particularly psychiatric medications, some can cause gynecomastia.
Well, thank you. Dr. Hines, why don't you finish this one up?
So in general,
so Dr. Hines, can you do like in church when they put the scripture up? Can you read it first and then talk about it?
Sure. So it's we're still talking about breast cancer screening, and it's screening should continue as long as a woman is in good health and is expected to live 10 more years or longer. So I'll just stop on that one. The reason why they make screening guidelines for someone who is expected to live 10 more years or longer is because the thought process is, if we're doing breast cancer screening and we're catching it at an early stage, if your life expectancy is shorter than 10 years, if your life expectancy is 2 years, then it may not be that addressing that cancer is the biggest deal in your life, in that individual's life right now. There may be some other things that are taking priority and might need to be more imminently addressed, dealt with, or because let's just be honest, sometimes it is what it is, right? That, you know, this person's not likely to have breast cancer be the reason that their life expectancy is shorter. So we're not necessarily going to go down that pathway now, because the other thing too is we're screening with the assumption that if we find something, we're going to do something about it. And if we're talking about somebody who has a shorter life expectancy, then the reality is that may, again, we might have other issues that we're already dealing with, and starting chemo, it might not be what we're going to do on somebody who's got a life expectancy of 2 or 3 years. Now, the next one is all women should be familiar with the known benefits, limitations, and potential harms linked to breast cancer screening. This is, again, when we're talking about having a relationship with your primary care doctor, gynecologist. And for example, like as I was saying before, mammograms aren't the best choice for everybody. So some people are up in arms because they're not getting a mammogram, when the reality is if you're 30 and you need breast cancer screening, mammogram may not be the best option for you, right? So there are having a conversation with your doctor about what's the best screening option for you. And then here's the other things: knowing your family history, making decisions and having conversations about checking for, gene mutations and things like that may run in your family, understanding your family's history, here's the other thing, understanding what to expect after getting a test done, right? If the answer is, if you've gotten a mammogram and your doc says you should get a letter from us in 2 weeks, I'm just making up something, and no letter comes, know when you need to follow up and check on that answer. Some people go with the no news is good news, and then things get missed, right? Because at the end of the day, there are humans. So when is your responsibility to make sure that you got the result, that you got the information that you were expecting? So those are some of the things. And again, potential harms, right? Linked to breast cancer screening. Having a conversation that can weed out excuses from legitimate concerns. And
what about breast self-exam, doctor?
So breast self-exam I think it's a level R, right? So there's mixed, you can do them. That doesn't necessarily do you harm. It's always good to be knowledgeable about your body. If you do breast self-exams, if you choose to do breast self-exams, then what I would say to you is, especially if you're still at an age where you're having menstrual cycles, do them at the same time in your cycle, which is not the same thing as the same day in the month, because most people's cycles are not necessarily exactly 30 days or following the calendar. And the reason why I say that is your breasts are going through changes during different stages in your menstrual cycle. So you can unnecessarily freak yourself out, because last month I checked my breast, 3 days before my first period. And then in this month, I checked my breast 2 days after my period, and they feel different. Well, that's a normal kind of phenomenon. Your breasts are going through changes, because remember, the whole purpose of having a menstrual cycle is your body's preparation to do things in case it's going to house a baby, right? And it preps, and then it goes, okay, no baby, all right, and then we're going to unprep, and then we do the whole thing over again. So your breasts feel different at different times in your cycle. So get to know how your breasts feel. But for example, if it's going to be the first day, I used to tell people to pick a thing. If it's going to be the first day of your menstrual cycle, then do it on the first day of your menstrual cycle. Pick something that you can remember.
Yeah. Dr. Neighbor, we forgot to do something. You want to do that?
I didn't forget. I was just waiting for you.
All right. See, Ivan, she blames it on me. Go ahead, Dr. Neighbor. You want to do that now?
Swear it, but anyway. Since we've been talking about screening and taking care of ourselves and this is not the first time we've had this conversation. We've talked about having a plan as far as COVID is concerned. When we have talked about different disease states, we have given you signs and symptoms to be on the lookout for. We've given you statistics about what happens in our community, at what age group, in which sexes, and at which age groups. So now I thought, two plus years into this whole process, it's time for us to get some feedback. So although Dr. Maxey did start with some screening conversation before we got a chance to do this, I want to ask everyone, as they say in the church, in our listening audience, to write down right now, 5 things that you're doing to take care of yourself. And then later on, we're going to ask for people to share their list with us so that we can see how effective our messaging has been, but more importantly, see how well we are loving ourselves.
So you want everybody to, on a piece of paper or on their phone,
Or on their chalkboard, or whatever they write on.
okay.
Can you
So-
repeat 5 things that we're doing to
Take
take
care
care of
of
ourselves? Okay.
Now, if this were TV, we'd have some music going while they write those 5 things down. We can ask Dr. Walks to sing a little bit.
We really can't. Maybe we just shouldn't.
All right, you've had enough time. We can move on. And then in a few minutes, we're going to start asking for people to share.
Okay. So this one, you're on a roll, Dr. Hines. Maybe being the family practitioner, you could just briefly finish this up.
Dr. Hines is on mute.
Yes,
That's important. Very well. Women should also know how their breasts normally look and feel, and report any breast changes, abnormalities. So we'll just talk briefly about the types that classically, the types of breasts are lumpy, right? They're not uniform tissue. They are lumpy, right? And they're lumpy intentionally because they are full of glands and fat tissue and ducts and things like that. Because again, what is their purpose? More than just to, be aesthetically there. They have a purpose for feeding a baby, right? So it is not uniform tissue. So some people's breasts are lumpier than others. Some people's breasts are denser than others. So knowing who you are, what your body feels like is important. Classically, the description for concerning lumps are usually going to be things that are hard like a pea and tend to be fixed. They don't move around, right? That's the classic description of a lump of concern.
Say an uncooked pea, right?
Yes, sorry. An uncooked, raw, firm, hard pea. I can't think of enough. If you've not felt a pea, that's the classic description. A small pebble. Hard is the distinction. It is not uncommon for women to have rubbery kinds of things that they sometimes feel in their breasts. Some women's breasts are more, again, cystic than others. Knowing where you stand, knowing where your breasts are, how your breasts normally feel can help you kind of distinguish, is this something that I've been feeling for a while, or is this something that is new? And as I said before, knowing about your family history. Lots of people who have, for lack of a better term, lumpier breasts. Oftentimes there's other people in your family who might have lumpier breasts too, right? Sometimes those things need to be dealt with just for, again, screening purposes to make sure that there's nothing else of concern. And sometimes it just gets noted, that's what it is, and this is your baseline, right? So knowing those things can be very helpful. Oftentimes, other things that are going to be of concern are going to be bloody discharge is oftentimes something that you don't want to promptly talk to your doctor about. Milky discharge, assuming that you're not pregnant, you're not on any medications that are going to be causing milky discharge, is something that you should talk to your doctor about. Not necessarily a sign of breast cancer, but again, the point is this: if something's happening new and different, right? And there's not a good reason that you're aware of for it to be happening, then that's a reason to have a conversation with your doctor to say, hey, this is what's happening. It hasn't been happening before. What should we do about that? And start.
Can I just tag on a little something to that, which is going to sound so obvious, and it really applies across the board. A lot of times we will say, and it's not untrue, that lack of access has been a barrier for members of our community to receive the kind of care that they need. When you made the comment earlier about a funky tumor, it took me straight back to the end of my second year in medical school when we began a course called Introduction to Clinical Medicine, which is where medical students begin the training in how to take a history and perform a physical. It's critical learning. And if you were blessed with a good teacher, it will stand you in good stead throughout your career. Well, I went in to do my history of this woman who was 72 years old and had breast cancer. Now, she had breast cancer that would aptly be described by Dr. Jocelyn Hines' medical term, funky tumor. I could not help but wonder, because this was her first admission, I could not help but wonder what took her so long to seek attention. And she told me, and she's not unique. I hope it is decreasing, but I still don't think it's unique. She did not want to have her breast examined by a male. And the only doctors she knew were male doctors, and she did not want to be checked. And so literally, most of her breast tissue was gone. And as you can imagine, we were in stage 50, if there's such a thing, in terms of the staging of her disease. So modesty is important. I get it. But again, find someone that you can form a relationship with and have the kind of conversation and examinations necessary.
I will also just add to that too is, and I said it, and I kind of said it before too. Sometimes just because no one's given you the name of something, you know something's wrong, right? You know something. Not going to talk to anybody or not going to see the doctor and again, we've got telemedicine, we've got all kinds of things, we've got all in the internet, there's all kinds of this show, like there's all kinds of, if something is wrong, right? Like waiting until it smells or again, it's visible from across the room. And I'm saying these things because I'm probably, we've all seen them, right? When that's, you've come in at that point. When you come in at that point, there's a lot fewer options, right? Than if you came in earlier, when you first knew something was wrong. I think for most people, there's oftentimes some clues, right? That something's not right. And hoping and wishing doesn't make that better.
That's true. So let's move on and then we'll go back to those questions that Dr. Neighbor Stevens had. So I'm going to talk about a minute about colon and rectal cancer and polyps. And there's a saying that most rectal and colon cancers are within 1 finger length of the rectal orifice. So it's like not necessarily way up there. So the American Cancer Society, the ACS, recommends that people at average risk of colorectal cancer start regular screening at age 45. This can be done either with a sensitive test that looks for signs of cancer in a person's stool or their bowel movement. And this is an exam where that you give a sample of your stool, and it can be done in the doctor's office where it'll actually, it's called hemocult. It'll change color, usually blue, I think. And there's also a visual exam, which is usually a sigmoidoscopy, which I don't know if they do sigmoidoscopy anymore. I used to do those, but most people get a colonoscopy where the doctor can actually look at the entire colon. And I remember when I had my first one years ago, I was very scared. One, being a man, a Black man, I'm not used to anything going up my other end. And the other, I was worried about, in my mind, I felt this is going to be painful. And the doctor said, I want you to count down from 10 to 0. And I said, 10, 9. I said, wait a minute, how long is this going to take? He said, we've been finished 30 minutes just waiting on you to wake up. So the way the test is generally done, you have total amnesia. You don't feel anything. And I was quite happy about that. Now, the guidelines say that people who are in good health with a life expectancy of more than 10 years should continue regular colorectal cancer screening through the age of 75. I guess I'm the only one on this moderator panel that's finished, right? Any thoughts on this so far, my doctors?
I'd just like to make a plea again that you talk with your family and find out what's going on. Because again, guidelines are based on statistics of what is likely to happen. But if your family history is such as mine is, where I have my father and his sister who both developed colon cancer after the age of 75, it does not sound like I need to cut it off at 70 or whatever that cutoff was on that previous slide. I need to take into account what is going on in my family. But you can't do that if you don't know your family story. So again, learn about your family.
You want to do these last 2 points on this slide?
People over 85 should no longer get colorectal screening. That is based on a couple of things. One is the life expectancy of 10 or more years. The other thing is the age when colorectal generally first appears. I'm willing to bet money that this one is going to change. And the reason I think this one is going to change is because, one, our diets are such that they put us at risk for developing colorectal cancer. And two, there are different things in our environment that can set us up for colorectal cancer. And if we're doing all that we can and are blessed with good genes, you might live to be 100. I mean, that may be your family's pattern to live between 95 and 100. So if you develop colorectal cancer at 85, you're cheating yourself of maybe 15 years based on your family statistics. All of this is to say you need to really have a conversation with your physician to make a plan that is appropriate for your situation.
Can I just chime in on, if you are someone who had a colonoscopy 10 plus years ago and remember that you had to drink the gallon of the Go-Lite of that nasty solution, again, those things have changed. So for lots of people, the preparation, so before you get a colonoscopy, you have to clean out your bowels. Well, cleaning out your bowels means basically taking something that is the equivalent of a strong laxative to get rid of all of the poop, so that then when you put the camera in there, you can see the actual walls of your colon. It used to be that you'd have to drink a significant amount of a laxative fluid that was not very tasty before getting your colonoscopy. And two things, if you didn't do it, your colonoscopy would oftentimes be unsuccessful because you wouldn't have cleaned out your system well enough to be able to see the walls. And for lots of people, it's a real struggle to drink that, to drink that much of the fluid. In general, in most scenarios, they have gone to a pill method that is less onerous than the former method. And it used to be in as Dr. Neighbors even said before, in the vein of excuses. So if that's one of the excuses that you're holding on to, that's not how they do it. That's not how they do it anymore.
I thought that drink wasn't so bad.
Then lucky you, because I've had people who sat in hospitals for extra days simply because they wouldn't drink the fluid.
Well, I will say, having had one almost a year ago now, that I was pleasantly surprised at the prep process. It wasn't a pill. Well, a pill was part of it, but what we were instructed to do was I had to drink a couple of bottles of Gatorade. And in that bottle of Gatorade was dissolved a bottle of Miralax, which was tasteless and did not change the consistency of the Gatorade. So, it was not difficult to chug over an appropriate period of time 2 bottles of Gatorade. And then it was followed up with the famous two or three little pills to finish out what the old folks would call purging.
Okay.
So let me just say that I think it's wonderful that you people that live in all your high-end communities and have the fancy pills or the Gatorade. The last one I had, they gave me a whole bunch of that stuff to drink. And I would just say that if you go to wherever you go, and the method they use still includes you drinking a whole bunch of stuff that doesn't taste good, tough it out. It's important. Not everybody gets everything, but they should be able to get a good look at your colon, because that's what you went there for. So follow the instructions, whatever they are, whether it's take a pill, drink some Gatorade, drink 2 gallons of Go Lightly, do your best to follow the instructions, because what you really want is a good exam.
So
I got a good exam. People said things to me that I wanted to hear, like, your colon looked great, Dr. Walks. Your colon was so clean. That's what you want to hear. You may not think you want to hear that now, but that's what you want to hear.
I tell patients after their colonoscopy, I say, you forgot to smell. But the last couple of points on this particular slide are that, one, everything we've talked about before is if you're at average risk, that you can use the little pill they sell on TV and look at your stools. But for people that might have higher risk, people that have polyps, people that have had a history of colorectal cancer in the past, people that have inflammatory bowel disease, either ulcerative colitis or Crohn's disease, those people might need more extensive, more often screening. And people who had radiation exposure to their abdomen. And then there are other people who've had hereditary colorectal cancer syndrome, such as familial adenomatous polyposis or Lynch syndrome. So there are different sets of guidelines, and certainly we hope those people not only have a primary care physician, but might even do well to have been referred to a gastroenterologist. So that's very important. We have a lot of very good gastroenterologists. So, Dr. Neighbor Stevens, do you want to see if any of our people have comments they want to make?
Yes, Simon, I would love for you to unmute, and I'm going to call on somebody. If you choose not to participate, we will take you at your word. How about, oh, I'm in the chat. No wonder I can't see. That's better. What about Lucky? Oh, I know who we're gonna go to. Let's start with Antoinette Drone, who greeted everybody at the beginning of the show with a happy Sunday. Do you care to share your 5? And then just to give her a prep, the next person I would ask to share will be Mrs. Hall. Simon, were you on mute?
I'm not seeing Antoinette Drone, Dr.
Oh, Lord, I
Davis.
hope I didn't make her hang up. What about Mrs. Hall?
Well, I'm not camera ready, but I can talk.
Absolutely.
I am a cancer survivor myself. I'm coming up to 5 years. And fortunately, I had uterine cancer, had endometrial cancer, and I found it with my symptom was 1 drop of blood. And I went to the doctor. I called the my health plan. I was in an HMO, and I called my health plan, and they told me, well, we can see you. You can come in and see somebody. They gave me, it was like maybe about maybe 6 weeks that I had to wait to go and see my my gynecologist. And I said, no, I'm coming in tomorrow. And she says, well, you can't do that. We don't take walk-ins. And I said, well, you don't have any appointments. Somebody's going to miss their appointment, because I'm going to pray that they do. And I'm just going to come. So I did. And I got in. And they scheduled me. I had an exam with the nurse practitioner. And she did an exam. She didn't really see anything. She says, it's not gonna be anything. But if you really want to, you can have a biopsy. And I said, yes, I really want to. So I had a biopsy in 2 days. And in that, a week later, I was told, well, when he did the biopsy, he says, I'll be shocked if we find cancer. It's not going to be cancer. Well, within 10 days, I was told I had cancer. And thankfully, I pushed for myself. I was my own advocate, because had I listened to the folks on the phone telling me that I couldn't get in to see anybody for 6 weeks, I wouldn't have been having my surgery in 6 weeks. So I had the surgery before I had surgery, chemo, and radiation. And thankfully, even though I was stage 1B, but I was grade 3 of 3 in aggression, and it had already started getting into my lymphatic system.
So I am so proud of what you did make them take care of you. But just a question, what are some of the things that you did before and are doing now in terms of taking care of you? Have you followed up on screening? What are some of the things you have on your list?
Oh, absolutely. I've had everything. I've had my colonoscopy. Colonoscopy, I don't have to go back for 10 years. I've done all of my screenings. I keep my regular appointments with my oncologist, and I have changed my diet. I cut back on, I stopped eating gummy bears. I used to love fruit snacks, so I don't eat that anymore. No fruit snacks for me. No sodas. I drink water. No juices either. I just drink water. And I cut back on chicken, mostly vegetables.
So your list is pretty complete. So let's go to one more person, Dr. Labor-Stephens, because some of this is included on some of the slides, but I like to hear at least one more person.
Well, I wanted to get a male participant. So what about Mr. Brooks?
Can we unmute Mr. Brooks?
All right.
He might be down in the islands, you know.
Well, he might be on
Clearly,
and listening.
yeah, clearly he is not.
There he is. There he is.
Hello there. I'd like to begin by just saying that my 98-year-old mother died last week.
Oh,
And she was 98, and she didn't want anything to be done that would extend life. She wanted comfort only. And I was there for the last week one-on-one with my 98-year-old mother. So I just love the fact that we participated aggressively. Everything was done beautifully. It was packed. The family was there, and we're committed to making sure the family stays as tight as we've been in the past. But 98 years is 98 wonderful years. I was listening to this program with a lot of interest in terms of things that we should be doing. I'm monitoring my weight constantly. I'm doing blood testing quarterly, getting vaccinations for COVID, shingles, etc., anything I need vaccinations for. Frequent monitoring of my eyes, heart, and everything else. And then fully understanding the family background has become even more important to understand why older members or those that have passed on, what did they pass on from? And in the African-American community, we don't do a good job. We get spooky about knowing that somebody had sugar or something. We got to get away from that. We got to understand what others have died from, and we got to do it that way. I got a beautiful family, son and daughter. Daughter's a doctor. Son runs a $2.2 billion company. They're already starting to monitor aggressively to make sure that there are no surprises.
Well, thank you very much, Mr.
Amen.
Dr. Brooks. That's really great, and we all join you in your mourning your loss of your wonderful mother. And,
Dr. Maxey, before we move on, Mr. Brooks, you shared with us before your caring for your mom, and I just wanted to acknowledge two things. One is the mother that you must have had for you to put in the time that you put in with her. My mother will try to thank me sometimes for something, and I will say to her, I'll say, Mom, people don't always get everything they deserve, but you almost never get more than you deserve. So if you're seeing your kids wanting to take care of you and wanting to spend time with you, you probably deserve it. So we've heard you talk about your mom before, and we know by the amount of time you spent just how much she deserved that. And I just wanted to acknowledge that you're a good son, man, and thank you for sharing with us what you experienced with your mom.
Thank you, guys. Thank you.
I want to also acknowledge the mother of Admiral David Brewer also passed. I believe she was 104.
Wow.
Wow.
Heard about her on our call, and I've had the good fortune of being able to commune telephonically with a lot of these wonderful mothers. We had to do a mother show one day, Dr. Neighbor Stevens. We've got a lot of good genes out here that we're to give credit to. Let's go to our next slide.
Mhm.
Just one with body weight, physical. Can we re-show that, Simon?
Your screen share button again.
Okay. You're making me do stuff that's beyond my capability.
You're 2
It's
for
good.
2. See, there you go. Now you're 3 for 3. You got it.
Yeah, it's good to know that you can follow directions, Dr. Maxey.
So you might be able to lower your risk of colorectal cancer by managing your diet and physical activity. I know Mr. Brooks also thinks he knows a little bit about throwing hands and about karate. So I don't know he's doing that. So being overweight or obese increases the risk of colorectal cancer in both men and women, but the risk seems to be stronger in men. So staying at a healthy weight may help lower your risk of colorectal cancer. We know that physical activity, being more active, lowers your risk of colorectal cancer and polyps. Regular, moderate to vigorous activity can lower the risk, and we should limit the amount of time you sit or lie down. That can also lower your risk. And increasing the amount and intensity of your physical activity to help reduce your risk. And diet overall, we know the diets such as vegetables, fruits, and this is what Dr. Cutter told us a week ago, whole grains that are low in, and also your diet should be low in red meat and processed meats. You know what my previous favorite food used to be? I hate to admit it, but I gotta be honest, is hot dogs. I used to love hot dogs. That's probably the worst food that you can eat, but they taste so good. So, and what they used to call lunch meat, that's a big problem for all of us, those things. Now, I know nobody on this call drinks alcohol, but a lot of studies have shown that drinking alcohol gives you a higher risk of colorectal cancer. That increases with alcohol intake, especially among men. So all of these 2 martini, 3 martini lunches need to be looked at with suspicion. So it's best not to drink alcohol at all. But if you do drink, we know that men have a higher tolerance for women than women do. So it suggests that women don't have more than 1 drink and men don't have more than 2 drinks of alcohol a day. And smoking is absolutely I'm going to use a word Dr. Walsh is going to get me for it, but smoking is about the dumbest thing you can do. It's put something in your mouth that's lit and drawing the smoke into your lungs, especially now that COVID is out there messing with it. So smoking itself is linked to colorectal cancer, a lot of other cancers, as well as cardiovascular problems. So smoking is a no-no. And one of my patient relations, when people come in my office, I say, man, I was just about to tell you how smart I thought you were until you told me you smoked. I usually get a laugh, but I get them on an anti-smoking. Go ahead, Dr. Walks.
So Dr. Maxey, I think that what you say is exactly right, and nobody should smoke. But people who do smoke tend to say that smoking makes them feel a little bit more relaxed. There's something, they get something from the smoking. It's not just putting something hot in your mouth. And so I think that it's important to explore that with folks and see if there may be some other things they can do that can help them to relax when they feel stressed. And that may help them to get away from the smoking. There are also some medications that we can give people to help them stop smoking. So I always want to look at the positive and look at what we can do. We could, Dr. Maxey, you and I can talk later about anybody we want. We can talk bad about them, just me and you. But talking to them, I think we should try to be a little bit positive in understanding why they're doing something that we think is bad for them, and understanding why it is that they can get some benefit from something else.
Well, let me ask you as a psychiatrist, what is the calming factor that oral gratification gives. Like some children, when they're stressed, they suck a thumb. Later, people put a cigarette in their mouth. Some people eat. Is there any legitimacy to the oral satisfaction that happens with certain habits that we have?
Well, Dr. Maxey, we see people doing this all the time. So clearly there's something going on with that. People will put matches in the corner of their mouth. People will put a toothpick in the corner of their mouth. There are all kinds of reasons why folks do what they do. And that's why I'm a big believer in therapy. I'm a big believer in talking with someone about whatever it is that's not useful and that's not making your life better. If it's not useful and it's not making your life better, let's me and you figure out how we get you to talk to someone that might help you understand better, not only what you're doing, but how to do something different that ultimately is going to be good to you because you'll feel better, and good for you because you'll have a healthier lifestyle.
Okay. With this slide, I'm not going to go into detail, but it seems to be a positive move for a number of reasons to have a normal level of vitamin D in your body. Low levels can be associated with colorectal cancer, kidney problems, bone problems, as well as issues with prostate. And we know that calcium and vitamin D work together. That's the subject of another conversation. And we know that also that vitamins, magnesium can play a good role with some of these cancers as well. But let's just go, and we don't have time to do everything today, but I want to make sure that we talk about this. And I'm going to pitch this to Dr. Neighbor-Stevens and Dr. Hines to comment on this hormone replacement therapy and what are the good things about it, bad things about it. What are your thoughts on this, Dr. Neighbor-Stevens and Dr. Hines?
So this topic is, in some ways, is very similar to the dialogue that has taken place around COVID. We thought we knew some things early on, and then new information was collected and analyzed, and then some different thoughts were brought to bear regarding hormone replacement therapy. But because there was all of the conversation that occurred about hormone replacement therapy in the early 90s when the Women's Health Study was initially released, for a time there was strong there was stated to be a strong association and a need for women to avoid hormone replacement therapy during menopause. And studies have continued on that, and the newer recommendations have backed off of that initial admonition that hormone replacement therapy was dangerous. It is being done in different ways at a much lower dose over a shorter period of time. But if you're a little confused about what's going on, that's why there's been a change in the information.
Okay, Dr. Hines?
Yeah, the only thing I would just further add to Dr. Neighbor-Stevens' comments are around, just as we talked about before, what are you using hormone replacement therapy for? If there are uses for dealing with menopausal symptoms, right? And in general, that's usually taking hormone replacement for around 5-ish years, right? To deal with some of the symptoms of being perimenopausal, right? And then there's hormone replacement for the purposes of disease prevention, like cancer prevention, heart disease prevention. So I think that's one distinction to be made, right? And then as Dr. Neighbor-Stevens is saying, the guidance has changed over the years. And pretty much, other than maybe some cases of osteoporosis or potential osteoporosis, it's not particularly recommended for disease prevention. But if we're talking about symptom management, then that's again a conversation for you to have with your medical team, right, around the risks and benefits, right? Because lots of things come with risks and benefits.
Let me ask a question that's current with some of the controversies going on in the news with a lot of sexual changes that are being made by the LBQ communities. And for example, and some of these processes involve taking of these hormones. Are there any increased risk that are associated with the sex changes that are out there?
So could I take the first stab at this? Because this was a conversation that was very vigorously discussed during the pediatric section meeting at the National Medical Association meeting earlier this month. And if nothing else, the takeaway from and there were multiple lectures around this from all angles. But the biggest takeaway on this is that the endocrinologic management of individuals undergoing any kind of transgender change activity really needs to be handled by an endocrinologist and not just the primary care doctor, because there are any number of issues, and I am by no means an expert in all of this, but there are any number of issues that have to be addressed. And so anybody undergoing transgender transformation really needs to be managed by a team, not just by one person, but by a team to manage all of the things that have to be managed.
I would agree with that. I was going to have a very similar, like, that is not my area of expertise. When I used to work in Baltimore City, we worked at a clinic that was very friendly to the LGBTQ community. So we had members of our clinic who specialized and who had taken additional trainings and certifications on hormone therapy and things that you need to do when transitioning the psychological aspect. To Dr. Neighbor-Stevens' point, it's a team, right? It's not just here, take these pills, right, and then go forth. So, and I honestly, I don't know about because what I think you're asking about, are there longitudinal or long-term studies as far as the impacts of taking hormones for these longer periods of time? And I honestly don't know. And I would be curious if there's a difference in those outcomes based on when you started taking, if there's any difference, based on when you started taking those additional hormone supplements and things. What we do know now in general is that, like anything else, there are consequences, risks, and benefits to everything.
Good. Let me raise one other question. Dr. Walks, if you want to weigh in, that's fine. I know a lot of men who get to the senior age, like some of us on this call are, we see advertisements about this pill, this a manly man pill, and this pill will make her happy. And are there any risks, the same question, of taking these pills, which usually have some form of testosterone in them? And actually, most of these are listed as controlled substances and require DEA to administer some of the ones that you prescribe. But you can get a lot of things off the internet that supposedly boost your testosterone. Anybody want to comment on the risk benefit of some of those, how that would fit into this?
Well, I thought you were talking to Dr. Walks before, but while I'll just jump in specifically to that one. You've got to be really careful about what you're buying on the internet, because a lot of those things are not regulated, right? These random remedies and things like that that you're buying off, that can be bought off the internet, especially from other countries and the like. You've got to be really careful about making some of those choices, because one, you don't know what the ingredients are. You don't know if they can interact with any of the other things that you may be taking. So if we're talking first, the first question is, one, check your testosterone level, right? Like, see if there's an actual deficit there, and then you can figure out what your options are, right? But I'm always cautious about, because here's the other thing, and I'll say this, think about like Viagra, right? The only thing Viagra needed to do was tell you that it was there, right? And how you could get it. And then people were knocking themselves down to go and get it, right? If I've got to sell it at 12 o'clock at night through some buy now, and then you can pay in 3 shipments later off the internet, and I need, famous athletes and stuff like that to advertise for it, if it really does what we're talking about doing, it'll sell itself. That's just because of the demand of what it's doing, right? Like, so be really careful and don't spend $1 million. Like, the number of times I have been in a loved one's, someone close to me's cabinet to be like, listen, this is not, it's got to go. Like, you can't keep it. It's not real. It's got to go. But I understand the urge, but I just think that sometimes people put themselves in a position, especially when you're talking about folks who already have heart disease and things of that nature, you can really be putting yourself in an at-risk situation.
Right. And
So
I've read the package insert on some of those things. They can mess not only with your heart, with your blood pressure, they can mess with your eyesight, a lot of things. So,
Don't leave out the liver.
yeah, liver. Go ahead, Dr. Walt.
So, Dr. Maxey, I think that a lot of this goes back to what Dr. Jordan always says about having a primary care doctor and about checking things with your doctor. I was talking with someone yesterday who wants to get in better condition, and my comment to him was, okay, you're a person of a certain age, well over 70 years old. I said, see your doctor first. Tell your doctor what you want to do, your primary care doctor. Tell him what you want to do, tell him what you want to take, and then find out whether it's time to get that personal trainer to help you work on your balance and your flexibility and your strength, because those are the 3 things that I think that seniors need to work on. And I've talked about that before, but I wouldn't advise him to just start doing that. And I don't think we should advise anyone to buy anything off the internet or order anything from any foreign country, because the question is, what do you want? What is it you're trying to do? And if your primary care doctor understands that he or she can help you with getting what you want in a way that's reasonable, if it's possible.
Well, good.
Gibson had his hand raised.
Who did? Dr. Gibson?
Yeah.
Dr.
I
Gibson?
did actually. Dr. Hines went straight to my heart when she warned folks about ordering medications, especially from places unknown, because the standard is not the same as a major manufacturer that I used to do quality control for when I was in pharmacy school. It's not like that in some places. As a matter of fact, you'd actually be horrified to see the conditions under which especially certain medications that come out of Asia are produced. So you take really, 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 really very serious chances when you take medications and you don't know where they're from. It's not like Miralax and Dopalax that you can get with Gatorade down at the local retail pharmacy. It's not like that, because those things, by the way, can make it easier for you to screen yourself against colorectal cancer. But the other aspirational, if you want to call them that kind of thing, products that are being aggressively marketed, especially on the internet. Caveat emptor, buyer beware.
I like that word you use, Dr. Aspirational.
Yes.
I know it's about time for us to leave. I just want to cover this one more topic, at least briefly. We'll come back to it. And that's who should be screened for cervical cancer and what is cervical cancer. And I'm going to pitch this again to Dr. Neighbor-Stevens and Dr. Hines, and they can abbreviate it if they would.
So I'll start it off with the younger end of the age scale, and I'll turn it over to Dr. Hines for the other end. So at the point any female becomes sexually active, then they should begin to incorporate annual cervical screening. I'll say that again. At any age that a female becomes regularly sexually active, they need to initiate annual cervical screening. I'll turn it over to Dr. Hines.
So we're talking about a pelvic exam, right? So a pelvic exam and a Pap smear is separate from a pelvic exam, right? And the Pap smear is the part where you take a sample, you've got the speculum, you take a sample, you brush it up against the cervix, and then they take it to the lab to look for abnormal cells. And that goes on. So again, the slide doesn't get into the timing because it kind of varies, again, based on risk, right? It varies based on sexual partners. It varies based on whether or not you have any high risk viruses or things like that in your system. But one of the things that sometimes does get people tripped up is when they've had hysterectomies. There are people who falsely believe, right, that if they've had a hysterectomy, they don't need to get any pelvic exams anymore. So let's talk about hysterectomies, right? So just remember high level female anatomy. You've got ovaries, 2 of them, fallopian tubes, a uterus, a cervix. Some people say hysterectomy because they've had a ovary removed, right? They may have had a uterus removed, but they still have a cervix. They may have had their uterus and their cervix removed. They may have had their ovaries, uterus, and cervix removed. All of those things are different, right? And they come with different consequences and different body changes. But what they all have in common is, even if you no longer have a cervix, for which you can get a Pap smear, because a Pap smear is specific to the cervix, you should still be getting pelvic exams, right? And I think that's what's at the further on the slide, because even if your cervix is gone, you can have other things that go on in your with your female anatomy, depending on what parts you still have or don't have. So knowing, again, because there was a time when the assumption was if you had a hysterectomy, they just went in there and they took everything, right? That's not how things are done so much anymore. Now, if we're talking about surgical removal of things, it is usually of the parts that are relevant to wherever the problem is. So again,
You want to briefly comment on HPV?
So HPV is a virus, human papilloma virus, which used to be thought to be only about genital warts. Now they know that there are different strains of HPV virus that make someone more likely to not only have cervical cancer, but also to have anal cancers, right? And it is considered a sexually transmitted disease, essentially, right? So they have vaccinations for the high risk strains of HPV that start for children as young as, I believe, 10, right? Boys and girls. And then you can get them up into, so adolescence is into your early 20s, right? So you can usually get it up until your mid 20s or so. And the goal, again, is to prevent anal cancers and cervical cancers that are related to these high risk strains of human papillomavirus. Oftentimes when you get a Pap smear, you will get a test for human papillomavirus usually at the same time. And in particular, looking for those strains of human papillomavirus. What human papillomavirus will do, especially in the context of your cervix, is it can give you abnormal changes in your in the cells of your cervix. Not all abnormal changes go on to be cervical cancer, but again, this is why screening is important, right? Because if you have abnormal changes, usually they're going to tell you to come back on some cadence, right? And then for some people, then your body will normalize because your cervix sheds a lot, and it's like kind of like almost like skin, right? Some of these cells fall off, but for others, the abnormal cells stay around and go on to become problematic precancerous or cancerous cells, and then you deal with those in whatever is the most appropriate way.
So Dr. Hines, one of the takeaways I think is that you mentioned children starting at age 10 or 11, whether male or female, could benefit from being vaccinated because the vaccine is more protective at that age than it is at a younger age. Is that correct?
So it's not so the purpose of getting the vaccines or targeting 10-year-olds is to intentionally get to kids before they are sexually active, right? That is hopefully at 10, right? You haven't become sexually active. So you're getting the vaccination so that before you have access to getting the disease, right? And the reason why they extend it to, like I said, the older adolescents, the young folks in their 20s, is because even if you didn't get vaccinated before you became sexually active, there is still benefit to getting vaccinated later on. Think of it like your zoster vaccinations, right? For older folks, just because you've had shingles, you can still get a zoster vaccination to keep you hopefully from getting it again, or if you do get it again, it'll be milder than it might have been.
So Dr. Maxey, let me jump in. Dr. Hines, you said something that really resonated with me. You said that, I think you said that the pelvic exams should start when someone begins being sexually active. And is that correct? Is that what you said?
I said it.
Yeah.
Or somebody said it. Okay. One of y'all said it. And the reason it clicked with me is because there are many things we don't talk about in our families. And one of the most common things that we don't talk about is young girls being, what we used to say, bothered, but being sexually assaulted by older men, friends of the family or in the family. And even when we find out this has happened, we want to protect our girls by making sure that we just keep them safe and we don't tell anybody. But
take those slides down.
But what I'm hearing you all say, Dr. Neighbor-Stevens and Dr. Hines, is that that's not the time to protect our daughters by not telling anybody. The way we take care of our daughters is by making sure that they're safe from whoever they're from, connecting law enforcement and all of that. But at the same time, making sure that we get them in for these kinds of beginning health screenings. Is that fair to say?
Correct.
And I think it's something that's hard for us to talk about, but we have to talk about it. If somebody in your family has been sexually assaulted when they're young, that's not the time to not tell anybody, because you're not helping your daughter. You're not helping this young person by not taking it, because you take them to the doctor and the doctor's going to report it. Well, what's more important?
Dr. Walker, it's not only young girls that are being.
You're right, Dr. Maxey. I was speaking specifically to the pelvic exam when folks are sexually active piece, but you're right, Dr. Maxey. Dr. Hines?
So the youngest person I ever delivered was a 12-year-old. I delivered the baby of a 12-year-old, and this 12-year-old was extremely immature, but she already had visible genital warts, which means she had clearly prior to, this particular encounter, there had been sexual encounters before that she was able to have developed genital warts, right? So to your point around, and I wondered, I just happened to be on the delivering at the time, and we had other things to talk about, but it would make me wonder if anyone had done a pelvic exam and seen that she had genital warts prior to this delivery point. Was there help she could have received? Who's to say, right? But the point is, sexually active. The other thing I will also say is when I used to have young girls who were sexually active and would ooh at the thought of a pelvic exam, hey, if you've chosen, right? If you, and y'all know me at this point. And what I would say is, if you can tolerate that, you can tolerate this speculum, right? So if you're going down that path, right? And I'm keeping it G-rated for y'all, but if you can tolerate that, then you can tolerate this speculum. Stop fooling around, right? And you've decided to make adult decisions, so it's time to act like an adult.
Well, thank you.
Yeah, and it is not uncommon that we used to talk about babies having babies. It continues to not be uncommon that young people have babies. I delivered a 14-year-old who had a 1-year-old at home. Right? So these things happen in our communities. And I think we have to be willing to, when we have conversations about self-care and women's health, we have to remember that sometimes that those women's health conversations go down well below the category of women.
Well, we call it preconceptual health. We like to call things, put perfume on things, but I have certainly taken care of multi-generational families, both the mother and the children.
Is that statement, Dr. Neighbor,
Under 21.
like lipstick on a pig?
It's in the same family.
Yeah. So I think we've had a good discussion today over some very important issues, and we have a lot more to come up in the future. And some of the people that are going to help us discuss these things are going to be people who are quite gifted and specialized, and even some of the deeper things that we have coming up. I want to just notify our advisory committee that we're going to have our meeting on this Wednesday at 5:30 for the healthcare providers who are on. We have interesting topics to discuss. It won't be a long meeting, but it will be an important meeting. And then Dr. Neighbor-Stevens, have we talked to, we didn't schedule 2 weeks from now, did we?
No.
Okay. So very good.
Scheduled September 17th.
Okay. Very good. And let's start with Dr. Hines. Any final comments, Dr. Hines? Thank you for delving into these slides so much for us.
Absolutely. I think, one of the things that just came up over and over again is the importance of knowing your family history as much as you can, right? And then also knowing what should be happening with your body, so that if you need to advocate for yourself to do something that might be out of the perceived norm, right? You can do so, whether or not that's knowing not to wait, like, nope, this can't wait 6 weeks, right? Or just because I've had my 85th birthday doesn't mean that, something ends for me automatically. The more you arm yourself with information, the better you can advocate for yourself and for your loved ones.
Well, thank you. Dr. Walks?
I just want to ask the indulgence of my co-moderators and everyone. You may have noticed me moving around a lot today and turning my camera off. I've got some discomfort in my foot. I should never have kicked Dr. Maxey. No, that's not what happened. But I've had to elevate my foot a few times, and it is not responding to normal pain management. So just want to let y'all know that I have not gone crazy. I just am moving around a lot today because my foot hurts.
So I don't want to be like the famous Dr. Oz and talking about his political person, but what is that disease that they say kings and princes have from eating so royally?
Dr. Maxey, if you're talking about gout, that is not what I have, and I'm going to just leave you alone this afternoon.
And plus, it would take a long foot to reach me way out here in California.
Oh, by the way, for those who didn't get the rest of what Dr. Maxey was saying, the meeting, he said that was at 5:30. That's 5:30 Pacific time. Is that correct, Dr. Maxey?
That's correct.
So for those of us on the East Coast, that's 8:30 p.m.
Thank you so much. Thank
Yes,
you
sir.
so much. Dr. Barbara Nabin-Stevens.
Well, again, I hope that we have engaged our audience. I hope we have educated our audience, and I hope that we have empowered our audience.
Okay.
Amen.
I've had, is Dr. Jordan on?
I do not see Dr. Jordan today.
I had him in my head all afternoon saying everybody needs a primary care doctor, and I wanted to give him credit for that.
Yeah.
And Dr. Hines, you sure did step up to the plate today. Thank you so much. I appreciate everybody's attendance. Have a great Sunday. See you next week. And Simon, again, thank you.
Good day, everyone.
Bye.
Bye-bye.